My name is Dr. James Rudd. I'm the clinical PI of the Maths and Healthcare Centre, and I'm going to be chairing the last session. Rachel unfortunately has had to nip off, and it's my great pleasure to introduce a clinical colleague from Addenbrooke's Hospital to do the first talk. Dr. Raj Jena is a radiation oncologist, so a cancer specialist, and he's going to talk to us about using machine learning to accelerate treatment workflows in radiation oncology. Just while we're preparing the first talk, could I remind you to please fill in the feedback form, which is in the folder, and hand it out to the desk at the end. Thank you.
Fantastic. So good afternoon, everyone. So it's a real pleasure to be here and to describe some work that's really been 6 years in the making, reaching out to some colleagues, Antonio Cremonesi and Ben Glocker, in fact, who's here in the audience in a previous incarnation when he was still at Microsoft, of something that started out as a bit of fun and has opened up into a nice clinical application. So it's just to walk you through the story, basically. So what we're going to talk about is just a little bit about radiation therapy, what it is, and how modern radiation therapy is actually delivered, and just how dependent we are on cross-sectional imaging. To look at machine learning and where it is currently in our field, which won't take very long. Then to go through a little bit about the particular project that we've been working on, a machine learning application for segmentation of anatomy for radiation oncology through the Inner Eye project, and talking about real world things that have happened as a result of that project, what it's actually meant to me as a clinician, what's coming to our clinic in the next couple of weeks. So that's really about solving the problems we face so far, and then I'm going to move into sort of areas of looking at, having got that technology on board, what we're looking forward to in the future. So solving problems that we anticipate, that we haven't got solutions for, adaptive radiation therapy, and then really looking from where we can move from there into radiomics and predictive models, particularly with a focus in radiation therapy, very sort of practical kind of work. Okay, so radiation therapy, I would say the unsung hero of cancer medicine. It is a proven and cost-effective treatment against cancer, has been for nearly 80 years now, and 40% of all of the patients who are cured of cancer are cured by radiotherapy, second only to surgery, which is 50%, chemotherapy 10%. So in the early days, this was what the equipment looked like. So this is a very small X-ray device that's actually aimed at the chest of somebody that has pulmonary tuberculosis. So a very primitive type of equipment. And from there, we've moved to this. So this is the latest equipment that we've installed in Addenbrooke's. This is my toy, and everyone at the hospital knows that. This is the Brainlab Novalis radiosurgery system. It is a robotic radiosurgery device that has active patient monitoring. It uses three-dimensional stereoscopic imaging to monitor the external patient contour 60 times per second. It uses the state-of-the-art imaging and radiation delivery to treat targets with sub-millimeter accuracy. And it will also use X-ray imaging and CT imaging in combination in order to ensure that we have the highest level of precision. Okay, so we have nice tools available to us now. And that's important because it is a big societal problem for us, particularly in Europe, because now with improvements in the outlook from dying from cardiovascular disease and other things, so if a stroke or a heart attack doesn't get you, then cancer will. And so sadly now, for 1 in 2 of us that's born after 1963, we're going to be diagnosed with cancer at some point in our lifetimes. And 1 in 2 patients who are diagnosed will need radiotherapy based on current treatment patterns. So what does that equate to? Well, in 2015, that was 400,000 new cancer patients that we needed to deliver radiotherapy to. And this has really been articulated within our radiation oncology societies to say, we need to wake up, this is a big problem, and we need to gear up to be able to deliver these kinds of treatment at a scale that we're not currently achieving. So what does that look like in real life? So this is a heat map, and it shows I'm very proud to be part of this and doing some modelling actually to compare the estimated demand for radiation therapy in different EU countries compared to what's actually available. And so you can see some of the Scandinavian countries that have invested heavily in radiation therapy have well-defined populations. They're fairly well supported. They've got probably an excess of treatment capacity compared to their radiation therapy burden. So their problem is they're looking to innovate. They're looking to develop better and better solutions, and they need workflow acceleration to do that. But for the rest of us in Europe, we're behind. We just need help to catch up to treat the patients that we need to treat. Okay? So we both need workflow accelerators, but in different ways, really, depending on where you sit within Europe. So the issue is that imaging is at the basis of modern radiotherapy treatment planning. We consume a lot of imaging. So we consume a lot of diagnostic imaging that gets integrated into the radiotherapy workflow. If the guys from Toshiba are still here. So that's our lovely Toshiba Aquilion that we have in the department. We use MRI, PET-CT, and we have lots of treatment technologies that are actually really imaging devices in surrogate. We just don't tell the rest of the hospital. Okay. And we're using image-guided radiotherapy because radiation therapy generally isn't delivered all in one go. If it's a curative treatment, it takes 5 to 6 weeks treating the patient each weekday. So we need to ensure that each day we remain on target to treat the tumour target. So what ML is available commercially? And here I'm going to widen out not just to radiation oncology, but to radiology, my sister specialty. So I think a lot of the focus has been on diagnostics. Is there a tumour? And I mean, my personal view on this is that there are workflow accelerations and second readings and things where ML is really valuable, and we've seen those benefits. But actually, as diagnosticians, radiologists are really very good. But what I'm interested in, and we've heard a little bit about this in the previous session, is the importance of segmentation. Now, in the radiation oncology workflow, this is really important because the start of our workflow is to build a digital model of the patient in a computer so that we can do three-dimensional treatment planning. And that means segmentation of the tumour and segmentation of all of the healthy structures that need to be shielded from radiation. So no segmentation, no radiotherapy, end of. Okay? So we're in a sort of interesting situation, really, to consume these types of technologies. So there are techniques that are based on what's called atlas-based auto-segmentation, where we use deformable image registration and bring over normal tissue contours. Some of those are available at commercial grade. We've evaluated several of them and thrown them out because the trouble is if they're not good enough and it takes you longer to fix up than it would do to start from scratch, no oncologist is actually going to use those tools. So that's a real problem. So we need something better, and that's why perhaps an ML solution like the one that we've been working on might be interesting. So this is the workflow. So I treat patients with tumours of the brain and spine. This is a glioblastoma, the most aggressive type of primary brain tumour in adults, and this is what I spend my time dealing with. So typically at 5 o'clock on a Friday evening, I'll open up my software package here, and on multiple slices of this patient's MRI scan, I will have to go through and painstakingly delineate the tumour and delineate all of the critical structures in the brain that we want to shield from radiation. Okay? It takes time. It takes me about 90 minutes to do that for one patient. It's error prone, particularly if I'm tired at the end of a busy week. I might miss a bit of tumour here, you see. It's operator dependent. You need to train and develop skills to be able to do this depending on individual sites. And we know from numerical assessment that there is poor intra and inter-observer consistency. So if I come back and segment this on a Monday morning when I'm feeling refreshed, it will be different. And also if I compare with that of my peer, I know it will be different too. So we developed an application working in conjunction with the InnerEye team to implement machine learning using the kind of cross-sectional imaging that we use for radiation therapy. We didn't use, the original project we did was focused on glioblastoma, using lots of different MR imaging sequences, using all the data that we had available, which was really cool, and we got some interesting stuff. But here we had to go to ground roots and say, well, look, most radiotherapy planning is just done on unenhanced CT. can we build solutions that work for this? And we started, regrettably for me, down in the pelvis. And the reason for that is that about 30% of all of the work that we do in our department is pelvic radiotherapy, mainly for prostate cancer. So it made sense as a workflow accelerator to start there. And so what you can see here is that we have an unsegmented scan where we need to identify the bladder, the prostate gland, the femoral heads, the rectum as well, which are sensitive structures to radiation. And so what we do basically is we have built into the software a machine learning model that can run on-prem on your computer or can run in the cloud. And we select the structures that we want the computer to segment. Even on a modest laptop like my own, it will take about 60 seconds and generate this segmentation. This normally takes about 15-20 minutes. So we see 6,000 patients per year in our department. 30% of them have prostate cancer radiotherapy, 25 minutes per scan. You do the maths. But what's interesting is that our performance is actually good. We set targets when we were designing the ML using dice coefficients for what we wanted to aim for that were comparable with inter and intra-observer variation. So if you like a Turing test, we wanted our segmentations to be indistinguishable from the human operators. And that's what we've been able to achieve, but it's taken a lot of work. We have not been able to use the raw data that came from clinics to do this. We have had to resegment to a grade that is suitable for machine learning. And if any of you working in this field, I would heed caution as to that. So why does this matter? Well, this is a really important study, the TROG study from Australia, that is often cited as why this matters. So the study was actually one where radiotherapy was not the question. It was for head and neck tumours of poorer outcome, where the control rate is about 50%. So in other words, 1% extra dose that you can give results in a 2% extra tumour control rate. So small differences matter in these patients. They were looking at adding in a hypoxia sensitizer that enhances the sensitivity of the most resistant part of the tumour to radiation. Radiation requires the presence of oxygen to persist its damage to tumours. So the study basically was not about the radiation, so they created a very clear protocol of what they wanted to do for the segmentation, and the question, the hypothesis is, does adding in the tirapazamine improve survival? Well, the study from its primary hypothesis was negative, but the problem was that there were multiple protocol violations, and it was severely affected by the poor consistency of the segmentation. And in subsequent analysis, what they did was they looked at good segmentation and poor segmentation, and this is disease control. So if you don't segment the tumour correctly, patients die, right? So it matters. And what's really interesting was this comment. So at a reasonable level of spatial resolution, consistency is favoured over spatial accuracy in combined modality clinical trials. So we want automated solutions that are good enough, that will pass the Turing test, if you like, but then are behaving in a very consistent fashion so that we can then add in our comparator when we're doing a research study, knowing that the radiation therapy element of it, the variation in that, is minimized as much as possible. So I think an important lesson there. So what does that translate to me? So as I said, in neuro-oncology, for me to segment this GBM patient takes about 60 to 90 minutes. With the inner eye technology using our original algorithms, including fix-up time, takes about 5 minutes, so about a 12 to 18-fold speed-up factor. So what does that mean for me? Well, it means I could treat more patients, but also it means I can focus on all more interesting things. I'm very interested in functional connections of the brain and interaction of that with the tumour, and actually I want to spend that time thinking about how I can optimize the treatment for this patient so that we control the tumour, but actually reduce risk to particular structures to allow maintenance of cognitive function, for example. So these kind of technologies are quite interesting because they can disrupt our traditional clinical workflow. So our clinical workflow at the moment is very simple. We acquire scans. We sit there on computers in darkened rooms and we draw around all of the structures that are important to plan radiotherapy treatments. We then go ahead and do the treatment planning, which is actually highly automated. It's effectively all numerical optimization. And then we deliver the treatment. So what we've got now that's just, actually we've just got permission from Information Governance to do this now, is that the radiomics tool we're using now in Addenbrooke's, and what we have is we have a device in our radiotherapy network that takes the pixels from the images that we scan, feeds them up to ML models that are actually based in the Azure clouds. And one thing that's made that happen that was released just earlier this year is Azure Confidential Computing. So this is end-to-end encryption of data that goes into the cloud for analysis. So the transmission, even at the actual computation stage, be it on a GPU or CPU cluster, and it coming back, is all encrypted. And that was a major enabler. So when we went to Information Governance and we said, we want a workflow doing what we'd already asked you to do, but instead of doing it on-prem, we want to do it on the cloud, they said, well, yeah, why not? Because they were happy with the arrangements. But what's really interesting about this is that if you want to implement continuous machine learning, you need the telemetry. You need to know when the human assessed that segmentation, was it good enough? Did they need to change it? Because it's that extra, it's getting that delta, that if you can feed that back into the ML models, makes it really powerful, particularly because we're not talking about thousands and thousands of patients, typically, we're talking about hundreds of patients. And then you do your treatment planning and you do the delivery. So next month, we'll be able to do this in the department, which is just fantastic. So that's about solving the problem that we face right now. But when we get excited about techniques like this, is that it means we can potentially move it into the area of where we want to go with radiation therapy. So for the kind of thing that we really want to do is adaptive radiation therapy. So and I'm going to tell you this now so that you can upset any radiation oncologist that you have dinner with in the future, okay? This is the elephant in the room. We take a patient that has a newly diagnosed cancer. We scan them, we generate segmentations, exactly where the tumour is and all the normal tissue structures. We plan a treatment, and we then close our eyes for 6 weeks, assuming that nothing moves, nothing at all, because we treat them with exactly the same spatial distribution of dose for the 6 weeks of curative treatment. And we know that's wrong, but hitherto we've not been able to respond to that. So look at this. So this is a patient who's actually got a uterine cancer, and this is the tumour at the beginning of treatment. And you can see it's quite bulky. It's extending down towards the neck of the bladder, which means the patient can't empty their bladder properly, so the bladder is full. And this is the relationship with the bony pelvis, and the rectum will be down here somewhere. So then we rescan them at week 5 of treatment, and a couple of things have happened. So the first thing, which is good, is that the tumour's shrunk, and because it's shrunk, the bladder dysfunction's improved, so the bladder is less full. And you can see that the geometry that we're dealing with here is very different to the geometry we're dealing with here. So it seems naive to treat the same radiation dose in this scenario as in this scenario. But we haven't got the tools to be able to do that at the moment. So what we need to be able to do is change our workflow. So we need to acquire the imaging, use the ML model in the cloud to quickly do our segmentations and plan the treatment. We image the patient each day, which we already do at the moment, but all that we do at the moment with our images is ensure our crosshairs are aligned. In other words, are we still on target for the centre of the tumour? But instead of doing that, we take the data off into the ML, we resegment everything. So we update our digital model of the inside of the patient, replan the patient, adapt the plan, and then treat. And ideally, we want to be able to do that whilst they're on the device. Remember, our treatment devices are both imaging devices and treatment devices. So this should take about a minute, ideally, to be able to redo all of that. That's the kind of goal of what we're trying to do. And if we can do that, if we can really scan, re-identify and track the tumour target as it changes every day, there's lots of nice things that we can do that are really helpful. We can optimise our targeting. We can potentially treat the patient in fewer treatments, which is an interesting idea. It saves on resources and it's less of a burden to the patient if they can come for 4 weeks of treatment instead of 6. We can reduce side effects, and you could see why, because basically we don't need to irradiate such a large volume of healthy tissues. And we can lower costs, so the overall cost, both in the direct treatment cost, but also more what I'm interested in is the indirect costs of looking after patients that get long-term side effects who are survivors of cancer, because that's a huge burden on the healthcare system if you cure somebody but they end up with long-term toxicity. Okay, And really the only way to do this in the clinic at scale is with some kind of machine learning system. It's the only way that that's actually going to work. And ultimately, hopefully this will all translate to better outcomes, and it means we can spend more time thinking about the patient and actually optimizing the treatment. So finally, the last thing, which is an area that I'm really interested in, particularly just recently I've joined James as an investigator here in maths, and it's by trying to combine techniques that we've got so far with simple segmentations that form the basis of any kind of radiomics analysis, with other predictive modeling techniques in radiation therapy, possibly using non-image data. So here's the thing. We know that our outcomes of radiotherapy are driven by tumor control and normal tissue toxicity. And basically, I can cure any tumor anywhere in the body if I deliver 120 gray of radiation to it. There's no tumor that will survive, okay? The problem is the patient may not survive around them. So that's a bit of an own goal. And this is expressed as these two sigmoid curves. So this is a function of the probability of tumor control as we increase dose. And this is the probability of normal tissue damage as we increase dose. And so what we look for is always a compromise that gives us a reasonable level of tumor control without unacceptably high levels of injury to the normal patient. Now, trying to model tumor control is very difficult. It's a complex, multifactorial problem that requires a very good understanding of tumor biology. That's a problem that cleverer people than me are working to solve. But normal tissue injury is a simpler problem. We already heard about some very nice modeling of lung, looking at how it responds to injury. So you get more consistent responses of normal tissues to radiation effect, even if they are multifactorial. And what's nice is we've got really large amounts of data, image and quantitative data, that are generated when we treat these patients and then follow them up. And basically, this isn't one sigmoid curve except for one patient. This is a population of sigmoid curves for the whole population. And what we really want to know is which of these population of sigmoid curves relates to the patient in front of us. What is their individual normal tissue response going to be to radiation? And that's where using imaging signatures and toxicity data, because we deliver the treatment, we're delivering a timed intervention over 6 weeks, we can acquire toxicity data during that time, and we do that with validated metrics. So we have this idea of being able to sort of continuously update a predictive model that learns from both positive, i.e. the event of a toxicity, and negative, i.e. the absence of a toxicity, to refine our prediction of what's actually going to happen to that particular patient. And when I heard about this, I was deeply regretful that I didn't even do A-level maths and I couldn't understand what they were talking about. But more than anything, I wanted it. I wanted it really badly. So this is what I'm working on at the moment. It's a project called Hamlet RT. We're going to try and capture data from about 1,000 patients who are receiving radiotherapy for these different tumor sites. It's going to be a collaboration with the group at Microsoft, where we'll grab the image data and do the image analysis to build on the MLs that we've been doing for segmentation, extend them slightly to see, can we do predictive ML just by looking at the images? So sort of early steps of radiomics, but in a very limited way in terms of endpoints from the image data. And then also to bring in, I've duplicated the caption there, but this should be actually using mathematical techniques, particularly these multitask Gaussian models, to look at the non-image data as well as the image data to try and build these continuous predictive models. And ultimately, this is what we want to do. So this is a patient of ours. He's a chap with a glioblastoma who sadly died earlier this year. And we want to be able to, there's a couple of things here. So he's holding on to his kids. He's been out playing with them. And you'll also notice that he's got a good head of hair. Simple things, right? Now, in order to do that, we had to customize his radiotherapy in order to avoid damage to the hippocampus and to certain areas that are critical in neurocognitive function, because that was important to him. And we also had to adapt the radiotherapy where possible to try and spare dose to the scalp so that he wouldn't turn bald, because he told us that his kids would be petrified of him if that happened, basically. So this is what we're really interested in. At the end of the day, is delivering. Well, sadly, he had a glioblastoma, so he wasn't cured. But we wanted to deliver uncomplicated control of tumours for a larger group of patients using these techniques. Okay, so I'll stop there and just say thanks to the guys at Microsoft that I've worked with, the guys in the hospital that are working on helping me with the proposal for Hamlet RT, and to Corolla for introducing me to the group here at Maths and just getting me wildly excited about what we might be able to do. If you are coming to RSNA, I know there's quite a few images here. Antonio Criminisi, my colleague in INRI, is talking at a plenary session about AI at RSNA, so please come and listen to him talking. Thanks very much.
Thank you very much, Raj. That was fantastic. Are there any questions from the audience? Yep.
I have a question about your the last curve where you show that you update over time. Do you update with data from all patients or only for the specific patient?
You update with all of the data from all of the patients. That's the idea.
So my question there is, because of ignorance of the field, but if you update your machine learning algorithm after every patient, which I think is interesting to do, but if that one patient is off for the whole population, can you make it worse, actually, your predictive model? And are there ways of controlling for that?
I'm probably not the best person to qualify to talk about. I mean, my understanding is that you're still using prior information from individual patients, because I think that's key. I mean, there are lots of situations where we use physiological parameters and you have a continuous learning model where you're always building on an update from the prior parameters for that particular patient. But each event is then actually going into the overall learning model, if that makes sense.
Yeah, just for myself, my understanding, I wonder if you're building up this machine learning algorithm, whether there's a risk that you include data points that will always cause some kind of bias in your prediction, and that the model could be better if you leave them out, and whether there is technologies to take care of that.
Yeah, no, I think that's a valid point. Yeah.
Any other questions? Ben?
So I was wondering, so I mean, with the segmentation, right? So at the moment, what we are trying to do is to replicate what the best human expert would be able to do, right? So you might be very good in annotating those things. So you will compare the automation to how well you would have done manually. But you have more information, right? You have actually, for lots of your patients, you know what the outcome was, how well did they respond to the radiotherapy treatment. So wouldn't it be interesting to take a machine learning approach that takes that into account when you try to do the contouring, for instance? There might be certain types of contouring that lead to better outcome or to better planning.
Yeah, undoubtedly. So I think talking about sort of convolving that continuous learnings, not just to the endpoint of the initial segmentation and its validation by a human observer, but the ultimate endpoint, if you like, for the patient, i.e. local control, where did the tumour relapse? And yes, I mean, that's one of the aspirations really of looking at this data set. You know, in glioblastoma, those events come quite quickly, sadly, but for some other diseases it may take a long time to accrue that data. And I think, you know, we need to think responsibly about how to actually collect that data, because if you start off on that process, then I feel there's almost a mandate to be able to kind of see it through to address exactly what you say, actually do the final correlations in terms of outcome.
Another question near the front here.
Yeah, two if I may. Just one, I think, for our kind of education, you made just a side remark about radiotherapy requiring oxygen. Could you just enlarge on that?
Sure. Okay. So so ionizing radiation causes mainly double-strand DNA damage at low doses per fraction. So what happens is that DNA is held in place by histones, large structural proteins, and what will happen is that if you break DNA, typically it will reanneal again. That's its natural process that it will do. Mm-hmm. So ionizing radiation breaks the DNA, oxygen then binds to the ends of the DNA strands, and that's what prevents the reannealing and allows that double-strand DNA to break, which actually damages the genome of the tumour cell.
So you're saying you're requiring the tissue to be oxygenated?
Absolutely, and it's
I
well
see.
known from experiments going right back to Tomlinson and Gray in the 1940s, where they actually put oxygen electrodes into tumours and quantified this.
Interesting.
Yeah.
The second question is very, very different. You showed curves correlating accuracy of segmentation with survival. Yeah. How on earth did you conduct that study? I mean, how did you define an accurate or an inaccurate segmentation?
So that was an interesting study.
Yeah.
So the protocol violations in that study triggered the study to be closed by the data monitoring committee, and the publication that relates to is not the publication of the endpoint of the study, but a subsequent analysis where they actually went back and they got the study management group to recontour every single patient that went into 0202. So therefore they defined a consensual gold standard amongst the people that created the study. So and also interestingly, they were all recruiters. So all of the recruiters' patients, funnily enough, where's the curve? Were on the yellow line, compliant ab initio.
So the recruiters, sorry, meaning...
The experts, the people who designed the study,
I see.
basically. And then what they did was then stratified the outcome in terms of local control according to the level of compliance with the actual treatment protocol. And that's how they generated that data. This is not an ethical clinical study to do. This is something that has been generated. Yeah, I've got my MDU subscription in here.
I've just got time for one last question, I think.
So is Microsoft doing clinical trials to check on this, or are they under ISO 13485, or where is that going?
So Radiomics, the application is just clearing for FDA approval. So we'll get FDA approval as a medical device. It's not the highest class as a radiation planning device. It's as a assisted device. The Agora is a clinical study. It has no IMP. So it is purely observational. We're just capturing the data, and so we'll work through the logistics of that. But that's not, that shouldn't be a particular problem really. So.
Brilliant. I'd like you all to thank Raj for a fantastic talk.